Given the rarity of the subject and the rarity of given the rarity of this subject and rarity of the incidence of cases like paracetamol poisoning I've seen only once in life, beta blocker poisoning I have only heard it once in life, and salicylate poisoning I have yet to see. So basically, what I mean to say is these are the traditional topics of the West, especially Europe. In United Kingdom, the drugs paracetamol and aspirin both are available over the counter, and because of the common incidence of these poisonings because of some psychiatric illnesses, it has been a traditional topic that has been taught in critical care illness. But practically speaking, very few cases come uh, with this diagnosis, or even if they do, uh, even if they do, their management is quite simple and has to be focused on the organ management. Salicylates as well as beta blockers try to affect most commonly the kidney aspect. So if we focus on the renal functions in ICU, we can both diagnose as well as manage these illnesses. Paracetamol tablet in our country comes in injections of in tablets of either 500 milligram or 650 milligram. If somebody has to consume paracetamol for suicidal or homicidal purposes, they have to take up to 10 to 12 grams of paracetamol. Means that they will have to consume 20 to 24 tablets so as to succeed in their self-harm intentions. Hence, it is not commonly seen. Most of the patients come with either 4 or 5 tablets. They just have transient illness of 1 to 2 hours, and after that they start improving. So it is not a very common as well as very important topic for Indian perspective. But still, we will be touching upon these subjects in next couple of uh, lectures. But today we are going to focus on kidney functions in ICU, which is much more important as well as has varied causes. So, as some of you might know that there are two kidneys in body, and the unit that is responsible for function of kidneys is nephron. Most of the almost all of the blood that is taking up the toxins or is responsible for worsening of acute kidney injury or responsible for occurrence of deranged RFT in ICU is because of the blood supply to Bowman's capsule. If the blood supply is less, then there will be no blood here. If there is no blood here, then there will be no oxygen supply and tissue hypoxia in Bowman's capsule. Hence, it will start getting damaged. If this blood that is coming up is filled up with toxins, because almost a highest level of concentration of toxin will come uh, in kidney, and that too in this Bowman's capsule. So this toxin has highest chances of getting affected by that particular toxin. Secondly, once this toxin is uh, gone inside the tubules, the concentration of is further increasing of this toxin and hence responsible for epithelial damage in the nephron itself. So if you understand that there are two main mechanisms, one is decreasing blood supply, second is some toxins or some agents come inside the tubules and they start damaging the epithelium and the lining of this nephron. Hence, they can be responsible for uh, deranged functioning of these nephrons. If this nephron starts dysfunctioning, and it leads to uh, worsening of renal functions. A third cause, which is not commonly seen in our ICU or for that matter in any medical ICU, is post post renal obstruction. In which case there is obstruction beyond collecting duct and the urine starts filling up in these pipes. So if there is increased urine in these pipes, there is increased hydrostatic pressure, and it will start compressing the epithelium lining and start damaging the endothelium of these cells. So that is not commonly seen. What you commonly see is either renal, which means toxins, or pre-renal, in which case the blood is not reaching it. So how do you diagnose, or how do you realize that some patient is having acute kidney injury? First of all, their urine output will start falling. This is the most common manifestation of acute kidney injury, the fall in urine output. See, if urine is coming, patient is in ICU for any matter, for any illness, and the urine has started decreasing. That means that either blood supply to kidney is less, or if the blood supply is adequate, then kidney is not able to function properly. Either ways, there is acute kidney injury. So oliguria is the most common manifestation of acute kidney injury in ICU. Worsening oliguria leads to anuria, and worsening renal functions lead to rise in creatinine. Creatinine is a marker which we commonly follow apart from urea for diagnosis of acute kidney injury. And finally, apart from cleaning the blood, kidney also plays an important role in maintaining the acid-base balance of the body. As Dr. Manjunath has already taught you in previous lectures, metabolic acidosis or loss of bicarb in urine or from body uh, is a function of kidney. So their main role is to preserve bicarb, but once kidney starts getting damaged, bicarb starts decreasing. Once bicarb is decreasing, then there will be metabolic acidosis. So various authors or various people have tried to diagnose acute kidney injury at an early stage. So it is common that even if the patient is having a normal urine output, normal in the sense ki 1 ml per kg urine is coming, but still kidney is getting affected. The real manifestation of kidney that I discussed in previous slide, that is falling urine output and rising creatinine, might happen after 24 to 48 hours. But once that period has come, then that means that kidney has already become damaged. So people have tried to diagnose acute kidney injury before um, urine output falls or creatinine rises. So how do we do that? We have to monitor some parameters in blood which can help us in diagnosing kidney injury. So creatinine is one of them, but it starts rising only 48 to 72 hours after the injury has occurred. So it is a late biomarker. Other biomarkers are KIM1, IL-18, and TIM2, and NGAL. NGAL means neutrophil gelatinase associated lipocalin. So these are common biomarkers which start rising even before the kidney injury has occurred. But unfortunately, they are not easily available. So if you want to do these markers, these are extremely costly and extremely rare to be done. Similarly, one of the good biomarkers is cystatin. Cystatin is available, but still not easily available. We don't routinely use it because the cost of cystatin is more than the cost of patient's ICU stay. So there's no point following cystatin. Only thing that we commonly do is follow up creatinine and clinical manifestations of kidney. Now, the range of creatinine is 0.6 milligram per deciliter to 1.3 milligram per deciliter. The range itself is more than the double. The lower limit is half of the upper normal limit. So if patient presented in your ICU has a creatinine of 0.7 and after 2 days in ICU stay, his creatinine has increased to 1.2, then even though it is within normal limits of creatinine, the patient has developed acute kidney injury. My idea of acute kidney injury might be different from your idea of acute kidney injury, and your idea might be different from third person. So to uniformize everything and for better communication among physicians, a criteria of acute kidney injury were laid down. The main purpose was that if I tell you that patient is in the grade 3 of acute kidney injury, that means that that what my idea is of acute kidney injury grade 3 is same as your idea of acute kidney injury. So international communication between physicians and intensivists is as important as research related to acute kidney injury. My ICU might be following one criteria and other ICU might be following different criteria, so there can be communication gaps, and my idea of acute kidney injury might be different from their idea. So to avoid those kind of miscommunications, two major criteria of acute kidney injury were laid down. One was rifle criteria, another was KDIGO criteria. So rifle criteria was the older one, and it is denoted by an acronym which means that R for risk, I for injury, F for failure, L for loss, and E for end stage. So that means that uh, risk, a patient is on risk when his creatinine rises by 50%, whatever his baseline was, and urine output has fallen below 0.5 ml per hour. Kidney injury rise by twofold of creatinine, failure creatinine more than twice upper normal limit. That means that 1.3 into 2, that is upper normal limit. Loss means requirement of dialysis, end stage means a requirement of frequent dialysis. But as you can see that these criteria are somewhat arbitrary. This a patient can have rise in 2 folds of creatinine, but at the same time can also have twice the upper normal limit of creatinine. So there is some confusion between these criteria later on with when international associations of renal disease identified that this is not optimal and cannot can lead to miscommunications between the physicians. They laid another criteria which is more commonly used and is more evidence based. This is acute kidney injury criteria or KDIGO. KDIGO means kidney disease index for global outcomes. So these criteria are much more stable and much more important, and they help you diagnose the severity of acute kidney injury. People have seen that patients who are in stage 1 recover fast, patients in stage 2 recover late. So these criteria are basically evidence based. So stage 1 is increase in creatinine by 0.3 milligram per deciliter, or 50 to 100% rise in creatinine from its baseline value, or urine output fall of 0.5 ml per kg per hour for at least 6 hours. Stage 2 is rise in creatinine by more than 100% and falling urine output of less than 0.5 ml per kg for 12 to 24 hours. And finally, stage 3, in which a dialysis is needed or kidney injury has occurred beyond the time limits set in previous stages. So these are simple to follow, pretty straightforward, and easy to diagnose. So we are discussing about acute kidney injury, but is it really important? So there are two types of kidney injuries. One is acute and another is chronic. Chronic happens in patients who are diabetic, who have hypertension, who are hypertensive, amyloidosis, and multiple myeloma, other things. Those patients do not require ICU, and the only disease in them is kidney, apart from other chronic comorbidities. But in ICU, a patient who is presenting with XYZ illness can develop AKI because of his baseline illness or things that is acquired in his ICU or the complications of the treatment that he has been given for his initial treatment. It is quite common. If you follow KDIGO criteria, you can see that up to 50% of patients admitted in ICU will have AKI at some point of their illness. 50% is a huge number. Reason being, AKI itself is responsible for death of these patients. So if you imagine a patient who is presenting in ICU with diabetic ketoacidosis and he is improving and he develops AKI because of any reason, his chances of dying have increased by 50% just because of his stay in ICU. Second, uh, their patient can present with AKI, like patient with scrub typhus illness or patient with um, sepsis. They already at the time of presentation have AKI, whereas patients who do not have AKI come to ICU or receive some medications and then develop AKI, that is in hospital related AKI. Most common cause that we see in our ICU is sepsis. There is source of infection is somewhere else, but that is causing a dysregulated host immune response, which is causing acute kidney injury, ARDS, and affecting almost every other organ. Commonly seen or other commonly seen types of ICU are types of AKI are trauma, in which muscles are crushed, myoglobin is released, and this myoglobin will cause injury to kidney by blocking the tubules. Similarly, drugs like cisplatin, cyclophosphamide, piperacillin, all these drugs have some component of acute kidney injury that we give. Nowadays, we are using remdesivir for COVID-19. Remdesivir itself is an extremely nephrotoxic drug. Colistin, which is now commonly used, is extremely nephrotoxic. In fact, it was taken off market because of nephrotoxicity. Second, affection, cardiac failure and hepatic failure by themselves and their cytokines because of any reason also affect kidney. Has been known as hepatorenal syndrome and cardiorenal syndrome. So what are the consequences? Just because urine output has fallen and creatinine has started rising, why should a patient die or suffer worse consequences because of this AKI? So if patient is not able to pass urine and temperature is well regulated in ICU, that means that uh, fluid is getting retained. Obviously, patient is taking feeds, patient is being giving IV fluids, IV injections, antibiotics. So lots of fluid is going inside the body, but is not coming out. A 60 kg person who is not able to pass more than 600 ml urine per day, that means that rest of his fluid which is receiving is either getting retained in the body or retained inside the lungs. So pulmonary edema is one of the important consequences. Second, if the blood supply to nephron decreases, then eventually a necrosis starts to happen in areas where the blood supply is not met by other sources of blood in nephron. So tubular necrosis starts to happen. Metabolic acidosis itself causes myocardial depression, uh, increased respiratory rate, and fatigue. Secondly, AKI causes myocardial depression, which causes hypotension. Uh, Hypotension causes worsening of tissue hypoxia and decreased blood supply to other tissues, further worsening the metabolic acidosis and functions of other organs. A rise in urea leads to encephalopathy. In ICU, patients who are in increased urea will start having irrelevant talks. You are not able to control them. Patient will not recover. Patient will not take their own medicine. Patient will continue to depend on ventilator. And last, but the most important thing that happens because of AKI is hyperkalemia. Rest all the things that you can do, you can manage with some medical management, but hyperkalemia is one thing that will kill the patient instantaneously. Uh, some Usually we take an upper normal limit of 5, but for some patient 5.5 can be fatal. For some patients 7 can be fatal, 8 can be fatal, but hyperkalemia is one of the common and most preventable causes of death in ICU. So etiology, I'm not going to discuss the post-renal causes because they are not relevant in ICU. But common causes for pre-renal are hypovolemia. Patient presenting to you with blood loss or lots of diarrhea, lots of vomiting. So lots of fluid is coming out, blood volume is decreasing, patient is going into shock, and that shock means that there is pre-renal vasoconstriction in those patients. So hypovolemia. Second is HRS or CRS, the hepatorenal syndrome and cardiorenal syndrome. Basically, what I tell you is in patients who are having liver failure, cardiac failure, to protect the main organs, that is brain and heart, what the body does is it causes splanchnic vasoconstriction. Splanchnic vasoconstriction means that blood supply to abdomen and all the organs in the abdomen decreases, and that decrease means that the kidney will also receive less blood. Less blood means pre-renal acute kidney injury. Then there is sepsis because of the cytokines and septic shock. And finally, abdominal compartment syndrome. Somebody operated in the abdomen. There is lots of infection. Fluid is pus is getting accumulated. The abdomen is getting filled up, and that means that blood cannot go from heart to abdomen because already pressure inside abdomen is very high. So if pressure inside abdomen is very high, that means that blood will also not go to kidney and hence cause acute kidney injury. Renal causes in which toxin is going into kidney is trauma, that is myoglobin, pigment nephropathy, that means uh, hemolysis because of the hemoglobin getting accumulated in kidney, drugs, cytokines released in sepsis, and other toxins like ethylene glycol, methanol, and all those things. So once you have diagnosed a patient with acute kidney injury in ICU, how do you go about it? History. You have to ask whether there has been a trauma, any evidence of sepsis like UTI or fever, any evidence of blood loss, either in gastrointestinal blood loss or somewhere else. Finally, any drugs that patient has taken or received which can cause acute kidney injury. In examination, you have to look for evidence of pulmonary edema, encephalopathy, and how much is the severity of acute kidney injury. Most important type work is fluid status assessment, how much a patient has received in past 24 hours and how much has been the urine output. That way you can calculate amount of fluid accumulated inside body of over past 24 to 48 hours. And finally, investigations like rule out abdominal compartment syndrome, CRS, HRS. You will do a USG abdomen. To diagnose acute metabolic acidosis, you will do an ABG. To stage a kidney failure, you will do an RFT. So basic investigation you will do for diagnosis of acute AKI. Once you have done that, you have to treat it. Finally, in treatment, what we do is, first of all, address the basic disease. Like in any illness, what we do is, you have to diagnose and prevent the cause of acute kidney injury. Like in sepsis, if you have diagnosed the patient is having infection somewhere in the body, it means that you have to give antibiotics, or what you have to do is you have to drain the source of infection. That is dealing with the basic disease. Once you have done that, you will see that your kidney functions are improving and other factors are also improving. Similarly, if you have consumed a toxin, you have to give an antidote. That means which will take care of the adverse effects of those toxins. If the patient is in hypotension, then you will have to give blood supplementations, or you'll have to give IV fluid supplementation so that blood supply to kidney can be reestablished. Secondly, fluid supplementation, there is hypotension, and once you feel that patient's kidney are beyond salvage and patient can die of the consequences of acute kidney injury, then you have to immediately start renal replacement dialysis. So renal replacement therapy, that is dialysis, will help you buy time for two things. Either the patient will start improving, kidney function will start improving, meanwhile when you are taking care of his basic disease. Second, the consequences of acute kidney injury, like pulmonary edema, hyperkalemia, they can be prevented in renal replacement therapy. So dialysis means that keeping the patient alive till the time kidney recovers. And obviously avoid nephrotoxic drugs. So what are the indications of dialysis? Indications of dialysis are pulmonary edema, severe metabolic acidosis, increased potassium, which can cause death, uremic encephalopathy, uremic pericarditis, and intoxications. Dialysis and acute kidney injury will take will play important roles in two scenarios. Either the toxin itself is getting removed. You understand? If the patient consumes ethylene glycol, you will start dialysis even when kidney have not being injured. The reason being dialysis itself will remove those toxins from the body. So dialysis has a therapeutic role in those patients. But in most of the patient, dialysis is started as a supportive therapy because patient might die of hyperkalemia immediately. So instead of waiting for kidney functions to improve, you start addressing hyperkalemia because it is a life-threatening emergency. So dialysis in those cases will be a supportive management till the time kidney recovers. So this is too much detail for you, but still you should know that dialysis can be hemodialysis. That we most effective is intermittent hemodialysis. Intermittent hemodialysis means 4 hours of dialysis, then after 24 hours, then after 24 hours. That is the most effective way of dialysis. Second is peritoneal dialysis. You give the fluid inside his peritoneum, uh, give it some time for the dialysis fluid to equilibrate, and then remove that fluid. CRRT and SLED. SLED is slow, low efficiency dialysis, and CRRT is continuous renal replacement therapy. CRRT means that as kidney is working 24 into 7, dialysis should also work 24 into 7. So they will attach the patient to CRT machine, and that way over 24 hours patient's blood will be circulated inside the machine. That way dialysis is slow but much more effective and much more physiological. SLIDE is a similar form of dialysis. It takes 16 hours, but the rate of blood that is taken out of the body is slow. Why I'm saying this is that patients in ICU frequently develop hypertension. Now, a patient who is having hypertension should be put on dialysis, and if you remove 600 ml of blood from his body into the dialysis machine, the patient will crash, isn't it? So, to and if you don't remove 600 ml of blood, then there will be no effective dialysis. So, CRT and SLED are advances on that particular principle. They will remove less amount of blood, circulate it, clean it, and then push it back before removing the next batch of blood. This is one thing. Second, some toxins that can be removed by dialysis. So ethylene glycol, most common poisoning in India, where dialysis is effective. Ethanol, salicylates, aspirin, valproate, and lithium. These are the agents. If the patient consumes these drugs, then dialysis should be done despite having no acute kidney injury. So there is a therapeutic benefit of dialysis as well. Dose modification, this is very important because once has acute kidney injury has set in, that doesn't mean that patient uh, because most of the drugs that we are giving in ICU are either metabolized by liver or are metabolized by kidney. So if kidney is injured and you are giving some medication which is metabolized by kidney, that means that there will be accumulation of metabolites of that particular drug, and then that drug will itself become a toxin. So what we do is we decrease the dose of uh, that particular drug in parallel to the the rise in creatinine. So you measure the creatinine clearance of a patient. Uh, Once you measure the creatinine clearance of the patient, you will change the dose. Three of the most commonly used medications for this particular method are resident azobactam and meropenem. So normal dose is 4.5 gram 4 times a day, but once renal functions deteriorate or creatinine clearance is decreasing, the dose is decreased from 4.5 gram QID to TDS to BD to 2.25 BD. You understand? At every level, we are decreasing the dose in parallel to the severity of renal dysfunction. Oh, yes. So more than 40 ml per minute creatinine clearance, CRCL is creatinine clearance. no dose modification is needed. If 20 to 40 ml, then half the dose 6 hourly, half the dose 3 hourly, and hemodialysis half the dose 12 hourly. It is also said that if the patient is receiving dialysis, then the drug has to be given after dialysis. Isn't it logical? But if you give hemodialysis patient before dialysis, then the drug will be removed during dialysis. Avoid aminoglycosides, absolutely. Avoid cisplatin, avoid NSAIDs, avoid amphotericin B. All those drugs are absolutely contraindicated in patients having acute kidney injury. Some of these drugs can still be given in stage 1, but it is better to avoid these drugs because their adverse effect will further worsen acute kidney injury, and if they worsen, there's hardly any chance of recovery. So what are my take-home points are that it is very common. You have to know the KKIN or KDO definitions by heart. There are consequences of acute kidney injury which can kill the patient. Most common causes that you have to know are hypotension, sepsis, and toxins, which can be pre-renal or renal. You have to know the basic management, avoid nephrotoxic drugs, treat the basic disease, and finally, do dialysis. You have to note the types of dialysis and what are the indications of urgent dialysis. See, patients on OPD basis who are having chronic kidney disease, in those patients, the indication of dialysis is different. In those patients, even loss of appetite, anorexia, or fatigability is the indication of dialysis. But in ICU, we wait till the indications of emergency dialysis are met, then only we move ahead for dialysis. So, thank you. Any questions?